Welcome to This Week in Urology. This week we're covering 10 notable papers spanning major guideline updates in oncology, emerging strategies in bladder cancer, and new clinical data in functional and endourology. Let's dive in. We begin with a major milestone for clinical practice, the 2026 update of the European Association of Urology, or EAU, guidelines on prostate cancer. In Part 1, which covers screening, diagnosis, and local treatment with curative intent, the multidisciplinary panel advocates for a risk-adapted screening strategy. This approach generally begins at 50 years of age and must be tailored to the patient's individualized life expectancy. To avoid unnecessary biopsies, the guidelines strongly recommend using multiparametric magnetic resonance imaging. When a biopsy is indicated, clinicians should perform a combination of targeted and regional biopsies rather than relying on one method alone. The update also introduces a new 5-tier EAU classification system to refine risk categorization. For staging, prostate-specific membrane antigen positron emission tomography, or PSMA-PET, is recognized as the most sensitive imaging modality for identifying metastatic disease. Regarding management, active surveillance remains the standard for low-risk disease and is now also recommended for highly selected patients with favorable intermediate risk, specifically ISUP grade group 2 lesions. For local therapies, hypofractionated radiotherapy should be considered for intermediate risk patients, while those with clinically node-positive disease should be offered radiotherapy to the primary tumor combined with long-term intensified hormonal therapy. Moving to advanced disease, Part 2 of the EAU guidelines addresses relapsing, metastatic hormone-sensitive, and castration-resistant prostate cancer. The panel emphasizes risk stratification for relapsing disease after primary therapy to guide salvage treatment decisions. The therapeutic landscape has expanded significantly, now incorporating androgen receptor pathway inhibitors, metastasis-directed therapy, PARP inhibitors, combination regimens, and PSMA-targeted radioligand therapies. Interestingly, the EAU panel notes that these recommendations are based purely on clinical evidence and do not account for regional variations in cost or resource availability. This European update closely aligns with the American Urological Association and Society of Urologic Oncology, or AUASUO, 2026 guideline amendments. In Part 1 of their amendment, which focuses on biochemically recurrent and metastatic hormone-sensitive prostate cancer, the AUASUO panel incorporates new evidence published through August 2025, offering updated guidance on imaging, germline and somatic testing, and management after local therapies are exhausted. Meanwhile, Part 2 of the AUASUO amendment provides an updated clinical framework for the evaluation and management of metastatic castration-resistant prostate cancer, detailing new treatment pathways and future directions in this rapidly evolving space, while noting that the existing guidance for non-metastatic castration-resistant disease remains current. Next, we turn to bladder cancer, where we see a major guideline update paired with a new systematic review that challenges aggressive treatment trends. The EAU has released its 2026 guidelines for non-muscle-invasive bladder cancer in European urology, focusing on TA, tone, and carcinoma in situ lesions. Key updates include new risk stratification tables, detailing risk factors for bladder cancer, and prognostic factors for progression in specific subtypes. The update also features 2 new tables, summarizing treatment options for Bacillus Calmette-Guerin, or BCG, unresponsive tumors, and introduces a new section on adding immune checkpoint inhibitors to BCG in selected high-risk and very high-risk BCG-Naïve patients. Crucially, the guidelines introduce a pragmatic de-intensification strategy to prioritize patient quality of life and optimize resource utilization during follow-up, supported by a new table on the clinical role of urinary markers. This cautious approach to treatment intensification is strongly supported by a systematic review and network meta-analysis. The investigators analyzed 5 phase 3 randomized controlled trials involving nearly 3,500 BCG-naive patients with high-risk, non-muscle-invasive bladder cancer to compare standard BCG against novel combination or modified regimens. The pooled results showed only a modest difference in event-free and disease-free survival. Specifically, the combination therapies demonstrated a 1-year and 2-year event-free survival rate of 87% and 82% respectively, compared to 84% and 78% with standard BCG induction and maintenance. While combination therapy with immune checkpoint inhibitors and BCG did reduce high-grade recurrences in trials with central adjudication, this modest benefit came at a steep cost. Severe grade 3 or higher treatment-related adverse events, occurred in 1/4 of patients receiving combination therapy, compared to just 6% of those receiving BCG alone. Furthermore, the combination regimens demonstrated no survival benefit. The authors conclude that routine systemic intensification with immune checkpoint inhibitors is not justified for unselected BCG-naive patients and should instead be restricted to highly individualized higher-risk subgroups. Our third theme highlights a major shift toward patient comfort, mental health, and refined clinical classifications across functional urology and endourology. In European urology, the EAU has updated its guidelines on urological infections, featuring a comprehensive restructuring of the entire framework to align with the new classification system for urinary tract infections. The 2026 update adds dedicated chapters on the diagnosis and management of herpes simplex virus and fungal urinary tract infections. It also provides updated, evidence-based recommendations on peri-procedural antibiotic prophylaxis for prostate biopsy, emphasizing rigorous antimicrobial stewardship to combat resistance. Concurrently, the EAU has updated its guidelines on neurourology, emphasizing early risk stratification, urodynamic evaluation, and regular surveillance to protect upper urinary tract function and optimize bladder dynamics. The updated guidelines incorporate refined terminology, a stronger patient-centered approach, and expanded guidance on neuromodulation, reconstructive strategies, sexual and reproductive health, and urinary tract infection management in neurological patients. Improving the immediate patient experience is also the focus of a prospective, multi-center randomized controlled trial, which investigated whether routine indwelling catheterization can be safely omitted after ureteroscopic lithotripsy. The trial randomized 180 patients across 4 centers to either a no-catheter group or a standard catheter group. On the first post-operative day, the incidence of lower urinary tract symptoms was more than halved in the no-catheter group, occurring in roughly 10% of patients compared to nearly 25% in the catheter group. Patients without a catheter also experienced significantly less urinary urgency at 1 and 4 hours postoperatively. At 1 month of follow-up, only about 8% of the no-catheter group reported distressing memories of their postoperative symptoms, compared to over a quarter of the catheterized patients. With complication rates including fever and urinary retention being statistically comparable between the groups, the authors suggest that omitting routine catheterization is a safe, effective way to enhance patient comfort. The long-term impact of urological interventions on patient well-being is further underscored by a retrospective cohort study, which examined the relationship between benign prostatic hyperplasia treatments and incident mood disorders. Using the TriNetX database, researchers analyzed over 10,000 propensity score matched pairs to compare endoscopic outlet surgery, such as transurethral resection, laser photovaporization, laser enucleation, or aquablation against medical therapies. Over 5 years of follow-up, patients who underwent surgery had a significantly lower risk of developing depression and anxiety compared to those on medical therapy. Specifically compared to alpha blocker monotherapy, surgery was associated with a 32% lower risk of depression at 1 year, a 24% lower risk at 3 years, and a 19% lower risk at 5 years. Similar protective effects were observed for anxiety. When compared to combination therapy of an alpha blocker and a 5-alpha reductase inhibitor, the protective benefits of surgery were even more pronounced, showing a 30% reduction in the risk of depression and a 23% reduction in anxiety at 5 years. No differences were observed for suicidal ideation or bipolar disorder, but the findings suggest that definitive surgical relief of bladder outlet obstruction may have profound positive benefits for long-term mental health. If you only have time for one paper this week, make it the systematic review and meta-analysis on novel BCG combinations in high-risk, non-muscle-invasive bladder cancer. This study provides a crucial reality check for clinical practice by demonstrating that adding systemic immune checkpoint inhibitors to BCG in treatment naive patients significantly increases severe toxicity to 25% without offering a survival benefit or a clinically compelling reduction in recurrence. It serves as a vital reminder to resist routine treatment intensification in favor of highly individualized patient-centered care. Here are the key takeaways from this week in urology. First, the 2026 EAU prostate cancer guidelines recommend a risk-adapted screening strategy starting at age 50 based on life expectancy, the routine use of multiparametric magnetic resonance imaging before biopsy, and active surveillance for select favorable intermediate risk grade group 2 patients. Second, Routine systemic intensification with immune checkpoint inhibitors in BCG-Naïve high-risk bladder cancer is not supported for general use, as it quadruples severe treatment-related toxicity to 25% without improving overall survival. Third, omitting routine indwelling catheterization after ureteroscopic lithotripsy is safe and significantly improves patient comfort, reducing lower urinary tract symptoms on the first post-operative day from 25% to 10%. Fourth, endoscopic outlet surgery for benign prostatic hyperplasia is associated with a significantly lower 5-year risk of incident depression and anxiety compared to both alpha blocker monotherapy and combination medical therapy. And fifth, the updated EAU Urological Infection Guidelines introduce a restructured classification system and new chapters on herpes simplex and fungal infections, while reinforcing strict antimicrobial stewardship for prostate biopsy prophylaxis. That's your roundup for this week in urology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.